Welcome to Uber School's comprehensive guide on hematologic pathology. I'm your host, Pete, and today we're diving deep into the world of blood disorders. Are you ready to become a hematology hero?
You bet, Pete. I'm Crash, and I'm pumped to explore the red, white, and everything in between. Let's make sure our listeners ace their USMLE. Step 1, Uber School style.
That's the spirit, Crash. Now, before we dive into nitty-gritty, let's start with a quick overview. Hematologic pathology is all about diseases of the blood and blood-forming organs. We're talking bone marrow, lymph nodes, spleen, the whole hematopoietic shebang.
Right on, Pete. And let's not forget, folks, this isn't just about memorizing facts. Understanding hematologic pathology is crucial for diagnosing and treating patients. It's like being a detective, but instead of fingerprints, we're looking at blood smears.
Excellent point, Trash. Now, let's start with the basics anemias. These are conditions where you don't have enough healthy red blood cells to carry adequate oxygen to your tissues. We can classify anemias based on red blood cell size into microcytic, normocytic, and macrocytic.
Hold up, Pete. Before we go further, let's hit our listeners with a USMLE-style question to get their gears turning. Ready?
Fire away, Crash!
All right, future docs. Here's a question for you. A 25-year-old woman presents with fatigue and shortness of breath. Her lab results show hemoglobin 9 grams per deciliter, MCV 75 fluid, serum iron 30 micrograms per deciliter, TIBC 400 micrograms per deciliter, ferritin 10 nanograms per milliliter. What's the most likely diagnosis?
Ooh, that's a good one, Crash. While our listeners ponder that, let's break it down. We're looking at low hemoglobin, low MVV microcytic, low serum iron, high TIBC, and low ferritin. Any thoughts?
Well, Pete, this classic presentation screams iron deficiency anemia. The low MCV indicates microcytic anemia, and the iron studies, low serum iron, high TIBC, and low ferritin, all point to iron deficiency as the cause.
Spot on, Crash. Iron deficiency anemia is the most common type of anemia worldwide. It's often caused by chronic blood loss, like in heavy menstrual periods, or inadequate dietary iron intake.
Exactly. And here's a pro tip for our Uber School students. Always remember the iron studies triad for iron deficiency anemia: low serum iron, high TIBC, low ferritin. It's like the holy trinity of iron deficiency diagnosis.
Great analogy, Crash. Now let's dive deeper into microcytic anemias. Besides iron deficiency, we have thalassemias, anemia of chronic disease, and sideroblastic anemia. Each has its unique features that help in differentiation.
Right you are, Pete. Thalassemias are genetic disorders affecting globin chain production. You've got alpha and beta thalassemias, depending on which globin chain is affected. They're more common in certain ethnic groups like those of Mediterranean or Southeast Asian descent.
Absolutely, Crash. And here's where it gets interesting. Thalassemias often show a microcytic anemia that's out of proportion to the degree of anemia. In other words, the MCV is really low, but the hemoglobin might not be as low as you'd expect.
That's a great point, Pete. And speaking of interesting, did you hear about Marcus Cooper's latest adventure?
Oh boy, what's he up to now?
Well, rumor has it that Marcus was studying thalassemia so intensely, he actually shrunk his own red blood cells. He walked around looking pale for a week before he realized what happened and had to unshrink them by memorizing macrocytic anemia facts.
Crash, you've got to be kidding me. That's impossible.
Of course it is, Pete, but it sure makes for a memorable story to help remember thalassemias, doesn't it? Now let's get back to business. What about anemia of chronic disease?
Yes, anemia of chronic disease. This is a tricky one because it can be either microcytic or normocytic. It's associated with chronic inflammatory conditions, infections, or malignancies. The key difference in iron studies compared to iron deficiency is that both serum iron and TIBC are low, while ferritin is normal or high.
Excellent point, Pete. It's like the body is hoarding iron in response to the chronic condition. And let's not forget about hepcidin. It's the main regulator of iron homeostasis and plays a crucial role in anemia of chronic disease.
You're absolutely right, Crash. Hepcidin levels are increased in anemia of chronic disease, leading to reduced iron absorption and iron trapping in macrophages. This is a key pathophysiological difference from iron deficiency anemia.
Now we're cooking with gas. Let's hit our Uber School listeners with another USMLE-style question to really drive this home.
Great idea, Crash. Here's one. A 60-year-old man with rheumatoid arthritis presents with fatigue. His lab results show hemoglobin 10.5 grams per deciliter, MCV 82 fluid, serum iron 40 micrograms per deciliter, TIBC 220 micrograms per deciliter, ferritin 150 nanograms per milliliter. What's the most likely diagnosis?
Ooh, this is a good one, Pete. Let's break it down for our listeners. We've got a chronic inflammatory condition, rheumatoid arthritis, mild anemia with a normal MCV, low serum iron, low TIBC, and normal to high ferritin. What does that spell?
If you said anemia of chronic disease, give yourself a pat on the back. That's exactly right. The chronic inflammation from rheumatoid arthritis, combined with the characteristic iron study findings, points us straight to this diagnosis.
Spot on, Pete. And here's a crash course tip for our Uber School students. Remember, in anemia of chronic disease, it's like the iron is locked up in jail. There's plenty of it around, normal or high ferritin, but it's not available for use, low serum iron and low TIBC.
That's a great analogy, Crash. Now let's move on to the last type of microcytic anemia we mentioned, sideroblastic anemia. This is a fascinating one because it's all about defective heme synthesis.
Absolutely, Pete. In sideroblastic anemia, we see ring sideroblasts in the bone marrow. These are erythroid precursors with iron-laden mitochondria surrounding the nucleus. It's like they're wearing iron necklaces.
Crash, your analogies are on fire today. You're right, though. Sideroblastic anemia can be inherited or acquired. The acquired form is often due to alcohol abuse, certain medications, or myelodysplastic syndromes.
And don't forget, Pete, sideroblastic anemia can give us a clue on the peripheral blood smear, too. We often see a dimorphic picture. Some cells are hypochromic and microcytic, while others look normal.
Excellent point, Crash. This dimorphic picture is a key diagnostic feature. Now, let's shift gears a bit and talk about normocytic anemias. These are anemias where the red blood cells are normal in size, but there just aren't enough of them.
Right you are, Pete. Normocytic anemias include conditions like acute blood loss, hemolytic anemias, and aplastic anemia. And don't forget, anemia of chronic disease can sometimes present as normocytic too.
Good catch, Crash. Let's focus on aplastic anemia for a moment. This is a bone marrow failure syndrome where the bone marrow stops producing enough blood cells. It's not just the red cells, white cells, and platelets are affected too.
Absolutely, Pete. Aplastic anemia is a serious condition. It can be inherited, like in Fanconi anemia, or acquired due to things like radiation exposure, certain drugs, or viral infections. Sometimes it's idiopathic. We just don't know the cause.
That's right, Crash. And the diagnosis of aplastic anemia is crucial. We typically see pancytopenia in the peripheral blood and a hypocellular bone marrow on biopsy. Treatment can involve immunosuppression, bone marrow transplantation, or supportive care, depending on the severity and cause.
You've nailed it, Pete. Now, how about we challenge our Uber School listeners with another USMLE-style question?
Great idea, Crash. Here's one. A 22-year-old man presents with fatigue, easy bruising, and recurrent infections. His lab results show WBC 2,000 per microliter, hemoglobin 8 grams per deciliter, platelets 20,000 per microliter, MCV 88 fluid. Bone marrow biopsy reveals a hypocellular marrow with fatty replacement. What's the most likely diagnosis?
Ooh, this is a classic presentation, Pete. We've got pancytopenia, low white blood cells, low hemoglobin, and low platelets. The MCV is normal, and the bone marrow is hypocellular. Sounds like aplastic anemia to me.
You've got it, Crash. This is indeed a textbook case of aplastic anemia. The pancytopenia combined with the hypercellular bone marrow is the key to this diagnosis.
Absolutely, Pete. And here's a crash course tip for our Uber School students. When you see pancytopenia, always think of aplastic anemia. It's like the bone marrow decided to go on strike. Nothing's being produced.
That's a great way to remember it, Crash. Now let's move on to macrocytic anemias. These are characterized by red blood cells that are larger than normal. The two main types we need to focus on are megaloblastic and non-megaloblastic macrocytic anemias.
Right you are, Pete. Megaloblastic anemias are typically caused by vitamin B12 or folate deficiency. These vitamins are crucial for DNA synthesis, and without them, cell division goes haywire.
Exactly, crash. In megaloblastic anemias, we see a disconnect between nuclear and cytoplasmic maturation. The nucleus remains immature while the cytoplasm continues to mature, resulting in large, oddly shaped cells.
And don't forget, Pete, one of the classic signs of megaloblastic anemia on a peripheral blood smear is hypersegmented neutrophils. It's like their nuclei decided to play a game of Twister.
Ha! That's one way to remember it, Crash. Now let's dive a bit deeper into B12 deficiency. This can be caused by inadequate intake, especially in strict vegetarians, or more commonly by malabsorption.
Right, Pete. And the most common cause of B12 malabsorption is pernicious anemia, an autoimmune condition where antibodies attack intrinsic factor or the parietal cells that produce it.
Excellent point, Crash. And it's crucial to remember that B12 deficiency doesn't just affect the blood. It can cause neurological symptoms too, like peripheral neuropathy and subacute combined degeneration of the spinal cord.
Absolutely, Pete. That's why it's so important to diagnose and treat B12 deficiency promptly. We don't want our patients walking around with tingling toes and wobbly walking.
You've got that right, Crash. Now, how about we hit our Uber School listeners with another USMLE style question to really drive this home?
I'm all for it, Pete. Fire away.
All right, here goes. A 65-year-old man presents with fatigue, shortness of breath, and tingling in his hands and feet. Lab results show hemoglobin 9 grams per deciliter, MCV 110 fluid, WBC 3,500 per microliter with hypersegmented neutrophils. Serum B12 level is low. What additional finding would you expect in this patient?
Ooh, this is a juicy one, Pete. We've got macrocytic anemia with neurological symptoms and low B12. The key here is to think about the metabolic pathways involved in B12 metabolism. Any ideas, folks?
Great lead-in, Crash. The answer we're looking for is elevated methylmalonic acid, MMA, and homocysteine levels. In B12 deficiency, these metabolites accumulate because B12 is necessary for their breakdown.
Spot on, Pete. And here's a crash course tip for our Uber School students. Think of B12 as a traffic cop. When it's not there, methylmalonic acid and homocysteine start piling up like cars in a traffic jam.
That's a great analogy, Crash. Now, it's important to note that while both MMA and homocysteine are elevated in B12 deficiency, only homocysteine is elevated in folate deficiency. This can help differentiate between the two when B12 levels are borderline.
Excellent point, Pete. And speaking of folate deficiency, let's not forget that it can cause megaloblastic anemia too. The symptoms are similar to B12 deficiency, but without the neurological manifestations.
Absolutely right, Crash. Folate deficiency is often dietary in origin, but can also be seen in alcoholics, pregnant women due to increased requirements, and patients on certain medications like methotrexate.
And here's a key point for our Uber School listeners. Always remember to check folate levels before starting B12 therapy in a patient with megaloblastic anemia. If you give B12 to a folate-deficient patient, you can precipitate subacute combined degeneration of the spinal cord.
Crash, that's an absolutely crucial point. It's these kinds of clinical pearls that can really make a difference in patient care. Now, let's shift gears a bit and talk about non-megaloblastic macrocytic anemias.
Ah, yes, the rebel group of macrocytic anemias. These include conditions like liver disease, alcoholism, and myelodysplastic syndromes. They're macrocytic, but they don't show the megaloblastic changes we see in B12 or folate deficiency.
Exactly, Crash. In liver disease and alcoholism, the macrocytosis is thought to be due to changes in the red cell membrane. In myelodysplastic syndromes, it's due to defective red cell production in the bone marrow.
Right, you are, Pete. And don't forget about hypothyroidism. It can cause a mild macrocytic anemia, too. It's like the red cells are moving in slow motion, just like everything else in hypothyroidism.
Another classic Crash analogy. Now let's move on to our final category of anemias, hemolytic anemias. These are conditions where red blood cells are destroyed faster than they can be replaced.
Hemolytic anemias, where red cells go to die young. These can be inherited or acquired, intravascular or extravascular. It's like a whole soap opera of red cell destruction.
That's one way to put it, Crash. Let's start with some inherited hemolytic anemias. One of the most important to know is hereditary spherocytosis.
Oh yeah, the condition where red cells think they're basketballs. Hereditary spherocytosis is caused by defects in red cell membrane proteins, most commonly spectrin. This leads to spherical, osmotically fragile red cells.
Excellent description, Crash. And don't forget, these spherocytes are prone to getting trapped and destroyed in the spleen. That's why splenomegaly is a common finding in hereditary spherocytosis.
Right you are, Pete. And here's a crash course tip for our Uber School students. Think of the spleen as a bouncer at a club. It sees these oddly shaped spherocytes and says, "Sorry, you're not on the list. Time to go."
Crash, your analogies never disappoint. Now let's talk about another important inherited hemolytic anemia, glucose 6-phosphate dehydrogenase, G6PD, deficiency.
Ah, yes, G6PD deficiency, the condition that makes fava beans a mortal enemy. This X-linked disorder affects the body's ability to protect red cells from oxidative stress.
Exactly. Crash. G6PD deficiency is particularly common in individuals of African, Middle Eastern, and Mediterranean descent. It's a great example of how evolutionary pressure from malaria has shaped human genetics.
Fascinating stuff, Pete. And here's the kicker. Most people with G6PD deficiency are asymptomatic most of the time. It's only when they're exposed to oxidative stress, like certain drugs, infections, or, yes, fava beans, that hemolysis occurs.
That's right, Crash. And when hemolysis does occur in G6PD deficiency, we might see Heinz bodies on a special stain of the peripheral blood smear. These are clumps of denatured hemoglobin.
Heinz bodies, not to be confused with the ketchup. And don't forget about bite cells, Pete. These are red cells where the spleen has taken a bite out of the cell containing the Heinz body.
Great point, Crash. Now let's move on to an acquired hemolytic anemia that's crucial for USMLE autoimmune hemolytic anemia, AIHA.
Ah, AIHA, where the immune system decides red cells are the enemy. This condition can be primary, idiopathic, or secondary to other conditions like lymphoma, lupus, or certain drugs.
Exactly, Crash. And it's important to remember that AIHA can be classified as warm or cold, depending on the temperature at which the antibodies bind to red cells.
Right you are, Pete. Warm AIHA is typically caused by IgG antibodies and is more common. Cold AIHA, caused by IgM antibodies, is less common but can be quite dramatic. Patients can have hemolysis just from exposure to cold temperatures.
Great point, Crash. And let's not forget the diagnostic test for AIHA, the direct Coombs test, also known as the direct antiglobulin test. This test detects antibodies bound to the red cell surface.
Absolutely, Pete. A positive Coombs test is the hallmark of AI-high. It's like catching the immune system red-handed in the act of targeting red cells.
Another classic Crash analogy. Now, how about we challenge our Uber School listeners with one more USMLE style question before we wrap up?
I'm all for it, Pete. Let's see what you've got.
All right, here goes. A 30-year-old woman presents with fatigue, jaundice, and dark urine. Lab results show hemoglobin 8 grams per deciliter, reticulocyte count 10%, LDH 500 UL elevated, haptoglobin less than 10 milligrams per deciliter decreased. Direct Coombs test is positive. What's the most likely diagnosis?
Ooh, this is a juicy one, Pete. We've got evidence of hemolysis with the elevated LDH and low haptoglobin, plus a positive Coombs test. Sounds like autoimmune hemolytic anemia to me.
Spot on, Crash. This is indeed a classic presentation of autoimmune hemolytic anemia. The positive Coombs test is the key to this diagnosis.
And here's a crash course tip for our Uber School students. When you see hemolysis plus positive Coombs, think AIHA. It's like the immune system is hosting a demolition derby, and red cells are the only cars invited.
Crash, your analogies are truly one of a kind. Now, as we wrap up this Uber School production on hematologic pathology, let's recap the key points we've covered.
Great idea, Pete. We've journeyed through the world of anemias, from the tiny microcytic cells of iron deficiency to the giant megaloblasts of B12 deficiency. We've explored the niche neighborhoods of hereditary spherocytosis and G6PD deficiency, and caught the immune system in the act with AIHA.
Excellent summary, Crash. And let's not forget the importance of understanding the pathophysiology behind these conditions. It's not just about memorizing facts. It's about understanding the why and how of these diseases.
Absolutely, Pete. Understanding the mechanisms will not only help our Uber School students ace their USMLE, but more importantly, it will make them better doctors. After all, that's what this is all about.
Couldn't agree more, Crash. And remember, future doctors, hematology might seem daunting, but with the right approach, it's fascinating and crucial for patient care. Keep studying, keep asking questions, and don't be afraid to dive deep into the red, white, and everything in between.
Well said, Pete. And on that note, we'll sign off. This has been Crash.
And Pete bringing you another Uber School production. Until next time, keep your platelets high and your LDH low.
And remember, in the words of the great Marcus Cooper, hematology is like a box of chocolates. You never know what you're going to get, but it's always bloody interesting.
Crash, I'm pretty sure Marcus Cooper never said that. But it's a great line nonetheless. Goodbye, everyone, and happy studying.